Good evening, friends. Good evening, all. I welcome all for today's Friday afternoon series lecture on orthopedics. Today we have a speaker, Dr. Rishikesh Badwe here. He will be speak on orthopedic in general practice. Now I hope hand over charge to President Dr. Rupal.
Good evening, all. Welcome you all for today's scientific session on behalf of GPA and Digital Technologies. We feel proud to have Dr. Rishikesh Badwe with us talking about our very routine problem. And as president, I also appreciate our members who have joined GPA group for serving as COVID warriors. And at the same time, I take privilege to request all of you to further come forward and join this responsibility of working for the social cause along with PMC. Now I have our today's convener, Dr. Manoj Deshpande, to introduce Dr. Manoj Deshpande. He's completed his MD in Pune and BAMS in 1993. Dr. Manoj is a very brilliant sport personality playing cricket, lawn tennis, outdoor sports, and at the same time a very active member of Shivajinagar Doctors Association along with GPA. I hand over charge to Dr. Manoj Deshpande, sir.
Thank you, Rupa. Welcome all participants in this afternoon session. Low back is a very common problem in our society and our daily OPD. Lot of patients are coming with complaints of low backache, and it affects their daily life. It's my pleasure to introduce Dr. Rishikesh Badwe. He is practicing as an orthopedic surgeon from 1998 in Pune. He completed his diploma in ortho in 1995, his MBBS in 1992. His area of interest is fracture fixation and bone metabolism. His academic interest, due to his academic interests, this meeting will be like a classroom with pen and board, and he took some models for demonstrations. And one request to all participants to keep your audio and video off during these sessions and post question on chat. I request Dr. Rishikesh Badwe to speak on approach of a GP to low backache. Thank you, sir.
Good evening, friends. It's a pleasure always to work with the General Practitioner Association of Pune. And my sincere thanks to President Dr. Mrs. Rupa Agarwal, Secretary Dr. Khedekar sir, and my dear friend, a very old friend, Dr. Praveen Darak, who is a scientific committee chairman for this year. And it has always been a pleasure working with him. And he always insists on those topics where the utility into day-to-day practice of for the general practitioner is important, and some value addition through the lecture should be there so that you can bring the whatever is spoken today into your day-to-day practice. So today's practice is today's topic is approach of a GP. So that's a objectionable word. This approach, what I will be talking for low backache, is probably the universal approach for any clinician, any physician, any orthopedician, anyone, any doctor for that matter. This approach is very, very useful, and it's a very simple one. Nothing great about it, but the points which will be highlighted are important so that nothing is missed in this very common element which we come across in day-to-day practice. How common is it? So that brings us to the first question. the problem which we are dealing or which we are addressing today, it is next to common cold. So you can understand the gravity of low backache. Huge amount of sums are lost in treating low backache, and absenteeism is one of the major issues with low backache. So man hours, work hours, and financial losses are tremendous due to low backache. So to understand this very common problem, first I would like to brush up with the knowledge of anatomy, because once you understand what structures are involved in low back area, then from where the pain arises, it becomes simple for me to explain. So just to brush up with the anatomy, you can see a model of whole spine here, right from cervical to lumbar region. It is a S-shaped curve is there, meaning thereby the cervical region has 7 vertebrae, which are in lordosis. The thoracic has 12 vertebrae, which are in kyphosis. This is the kyphosis, that is convexity posteriorwards. This is convexity anteriorwards for the cervical spine. And again, lordosis in the lumbar region. So lumbar region, which we will be talking about, is lordotic in shape. Then comes the sacrum and the hips. This is the front view you can see. Now we will be focusing on these 1, 2, 3, 4, and 5 vertebrae, which are present in the lumbar region. So moving on to the next model, which will elaborate the structures involved. So that makes it simpler, I suppose. So there are 5 vertebrae in the lumbar region with the lordosis, that is convexity forward, concavity posteriorly. So each vertebral body is separated from the other vertebral body by an intervertebral disc, right? So this is the vertebral body, first vertebral body of the lumbar region, L1, this is L2, and this is the intervertebral disc. And similarly, the chain goes on. So by and large, the spinal column, right, from anterior to posterior, the spinal column is divided into 3 regions. The anterior column, that is made up of vertebral bodies alternating with intervertebral discs. Then comes the spinal canal. Can you see that? This is the spinal canal which transmits the spinal cord, which is in continuation with the brain upwards. And then the posterior structures. You can see these posterior structures from side. What are these structures? So these are the spinous processes, the zygoapophyseal joint, or the intervertebral joint. So this is the joint. Can you see that? Yes, this is the joint, or this is the joint. So superior articular process of inferior vertebra joins with the inferior articular process of the superior vertebra. So there are 2 joints at each level, the right and left. Apart from this, posteriorly, the major structures which are not seen in this model are interspinous ligament, intertransverse ligaments, paraspinal muscles, and the joint capsules, right? So this is the structure by and large. Now, what is the intervertebral disc? It is again made up of, so this is bone, typical hard bone made up of, mostly the vertebral bodies are made up of cancellous bone, and it has a cortical lining at the borders. The intervertebral disc is again made up of 2 histopathological variety, that is the annulus fibrosus, which is a tough fibrous like, I hope everyone understand Marathi, sutali sarkha kadak asta, and in the center of this annulus fibrosus is the main functional disc, which is called as the nucleus pulposus, 80% of which is water, 20% is solid. That solid is made up of protein. So the protein binds these water molecules to give it a pulp-like consistency, and thereby the main function of the intervertebral disc is to absorb the shocks, whatever the body receives while standing, sitting, bending forward, riding a vehicle, squatting, and all the daily activities. So in short, the intervertebral disc is the shock absorber of the body. Now, if you can see, these are the nerve roots which are responsible for the supply of the lower limbs. Now, after saying that, the peculiar thing about the anatomy of this part of body is there are so many structures in such a small area. Got that point? So there is a body, there is a vertebral disc, there are ligaments, there are muscles, there are joints, there are capsule. Then the important structure which is protected by the spine is the spinal cord, which is the main neurological structure controlling the lower limbs at this area at least. So many structures are bound together in a very small space, and that makes low backache a very difficult as to pinpoint from where the pain is coming, because it is difficult to differentiate. But if we look into the characters, the other criteria of history, then it becomes, as we proceed through the lecture, you will understand that it becomes simpler, easier, and really interesting as well to come to a diagnosis of from where the low backache is arising and what should be the approach to a patient with low backache. So the important part now is usually what happens with aging. So that is what I will term as pathogenesis of low backache. This is the standard or the commonest cause of low backache I am talking of. Low backache, if you look into the slides, I have categorically avoided going through the slides because slides enumerate so many things that it is difficult to catch up with the slides. So I will be talking over the model and I will be trying to write some notes on the screen so that you will follow it in an easier way. So typically what happens is this spinal column has now two functions, as you can understand. One, the most important is transmission of weight of the body to the sacrum. So this is where the center of gravity of our body is at sacral second vertebra when we stand. Okay. So where exactly my pointer is pointing, that is S2, that is the center of gravity, and the weight transmission is through the vertebral bodies and the intervertebral disc. So that is function number one. Function number two is to protect the spinal cord, right? So it is a RCC column of our body. Now, if you consider the RCC column of any building or any static structure, it doesn't move. This is a beautifully made RCC column, which also has the capacity to move, but then it becomes liable to many other disorders. Like, for example, the weight transmission. If a person of 60 kg is standing erect, the center of gravity is somewhere here, and 60 kg is passing through this. It is as simple as that. But if a 60 kilo person bends forward with an angle of say 30 degrees, he doesn't fall down because the posterior muscles, the anti-gravity muscles, this is a very important point. The anti-gravity muscles on the back side will pull that person from falling down. That is how the balance is created. Now, once this balance is created, it is created over a fulcrum. So that fulcrum is the spinal column or the vertebral bodies or the intervertebral. So all the force is concentrated by vectorization principle. With what angle the person is bending, what weight the person is carrying, what the person's weight is, all these factors come into count when as far as the weight transmitted here at the L4, L5 junction or L5, S1 junction is concerned. With this principle, if a person squats down, 3 times the body weight is passed through the center of gravity. Imagine 180 kgs for a 60 kg person. So 180 kg is beautifully balanced because the musculature and the body mechanism. Once this musculature goes weak, 180 cannot be transmitted, so backache occurs. That's the major cause. If a person is sitting in chair, like right now I am sitting in chair, so twice the body weight approximately passes through the lower back area. That is how the physics goes there. Now, what happens with age? As I told you, nucleus pulposus is made up of 80% of water and 20% of protein, which binds the water to make it a pulp-like structure. Once we age, the water content starts reducing. So the intervertebral disc starts becoming harder and harder. And the shock absorbing capacity of these discs reduces. Once that happens, what happens is the joint which I told you, which is at the back side, this is the joint, right? This is the joint. This, or you can say this joint. This is easier to understand. So this joint. These joints are put to extra load because the discs are not functioning properly. This happens with everyone, right? So once this joint starts bearing the load, these joints in the vertebra are as like any other joint in the body, like these phalanges. They have cartilages at their end, smooth cartilage at the end. And when the cartilage bears the load, it undergoes degeneration. Then, as in any other joint, the joint capsule swells up. There is effusion in the joint, and that is called as degeneration disc disease or degeneration of spine or lumbar spondylosis, or in vernacular language or the common language, gap padne. So there are so many terminologies to this, but the pathogenesis of this degeneration and the commonest cause of backache is this, what I have told you. That is the pathogenesis. Now coming to the diagnosis, how to approach a patient. That's our today's topic. So let me tell you that 90% of the diagnosis is done only, believe me, 90% can be depicted only through history taking, not even touching the patient, not even examining the patient. Examination comes later. That is the importance of history taking. And in history, as you all know, there are simple points. So we will go through each point and what that particular point signifies as far as the cause of backache is concerned. We will try to tackle it then and there. So the topic becomes very simple and interesting. So coming to the history, as the patient enters your room, you know approximate age and sex. So age and sex are important as far as the pathology concerned, or the pathology of the low back is concerned. Now, how that is so, we will divide the age into three major areas: young age group, middle age group, and old age group, right? So you can write down this if you want to. I'll start sharing the whiteboard here and I'll try to write. Forget about my handwriting. Okay. The shares option. Yes, age. So age, as I said, young, middle-aged, and old. So what are the causes commonly seen in young age group? So we'll turn to young. So young people will always have, once you see a young patient, you should think of these things. Muscle spasm, that is PSMS, paraspinal muscle spasm, commonest cause. Then prolapsed intervertebral disc, acute ligament strain, then inflammation, that is sacroiliitis or discitis, rarely infection. Okay, So these are the commonest causes in young age group. Inflammation and infection are less likely. So paraspinal muscle spasm, prolapsed intervertebral disc, and acute strain. Because these individuals are very active, they move around two-wheelers in our city especially, and they are liable to having muscle injury very easily. They are involved in lifting weight during household activities. So PSMS, paraspinal muscle spasm. Just a word about it. What is spasm actually? So spasm is something related only and only to skeletal muscle. No other muscle will go into spasm. Cardiac muscle never goes into spasm, neither the smooth muscles. So skeletal muscle contracts when it is given a proper stimulus, right? So if I wish to contract my biceps, the musculocutaneous nerve will send a signal to biceps, it will contract, and according to my will, it will relax as well. But what happens in spasm is the stimulus which led to the contraction of that muscle that has ceased to act, and still the muscle is not relaxed. So that stimulus is so strong, or that injury is so strong, that pain producing substances which have accumulated due to the injury are so strong that they keep the paraspinal muscles in continuous contraction, which we call as spasm. So that is paraspinal spasm. Now prolapsed intervertebral disc. So this disc, if the weight passing through the disc is beyond the capacity of the shock absorption of that disc, it creates small microscopic injuries in the annulus fibrosus that leads the pulp to come out. Till the time that the pulp is contained by the annulus, it is called as disc herniation. Once the annulus breaks out, it is called as prolapse. Once the disc comes out, it comes in contact of the immediately next structure is the nerve root, right? So it comes in contact with the nerve root, starts pressing it, and backache starts. So that is one of the reason of backache. That is how PIVD acts. Acute strain. I talked about the interspinous ligaments, right? So these interspinous ligament can get torn during lifting of weight or any other day-to-day activity. So there it can cause pain in the same way. Now coming to middle-aged. What is common in middle-aged age group? So if you see a young patient with backache, think of these things. And if you see a middle-aged, most common is, again, paraspinal spasm, chronic low backache, that is episodic. He or she will complain of backache on and off. So over a period of time, in last year I had say 4 episodes of backache which led to me of incapacitation of work for 4 days consecutively, 5 days consecutively. So that is called as chronic low back pain. That is seen in middle age group. Why, I'll tell you. Then there is something called as acute on chronic. And obesity in middle age group is very common, right? So after say the age of 40, 45, people start gaining weight, and obesity will shift the center of gravity slightly anteriorly because of the tummy. Okay. So once that center of gravity is shifted anteriorly, the posterior muscles are made to act furthermore, which leads to backache, because they have to balance much more weight on the anterior side. So the posterior muscles will have to balance it more. So obesity is one of the common cause in middle age group. So think of it as a cause. Acute on chronic. So first coming to PSMS, I have covered. So chronic low back pain. Why does it occur? I told you the pathogenesis. The disc loses its fluid. There is strain on the joint. The joints undergo degeneration. They are innervated, and that will lead to low back pain. Now, such a chronic low back pain is occurring, and sometime in life, what happens in acute on chronic? Such a person suddenly goes undergoes lifting of heavy weight or a strong jerk while riding two-wheeler, and it leads to prolapse of disc. So this is typically acute on chronic low back pain. So that you should take into consideration. Acute on chronic. And in old age, coming to the last, now these all things are going to get repeated in the other areas as well, but with different perspective. In old age, what is the common cause of backache is osteoporosis. So instead of thinking other things, first think of osteoporosis, right? And osteoporosis will lead to vertebral fractures, as you know. Second most common cause in old age is facet joint osteoarthritis, facetal OA. Pathogenesis, I have already explained. The discs will not bear the weight, the joints will undergo degeneration. Now, this will be often associated with radiculitis in old age or in middle age as well. We can consider this in middle as well. What happens is, there is a law called as Wolff's law. Stress will lead to strength. So if the joints are undergoing stress, it will lead to increase in the strength, because body feels that here the weight is more, so body needs to have more bone or more strength there. So bone is grown, and that overgrown bone is called as osteophyte. And this osteophyte, in immediate vicinity, there is the nerve root, will pinch over the nerve root and cause radicular pain or nerve root pain. So radiculitis associated with backache is very common, of course, in PIVD, plus in degeneration as well, but not in young patient. Radiculitis is common in young patient if there is acute PIVD, but in middle and old age, it will be due to degeneration or facetal OA, right? I told you about the anti-gravity muscles. In old age, what happens is these muscles start weakening. That is called as sarcopenia. And their capacity to hold the body against gravity reduces, and that leads to backache. So sarcopenia is another important cause in old age group. And most important, what you should think once if you encounter an old patient in your OPD with backache is secondaries of a primary tumor, most important, or primary tumor of the bone. Usually spinal means the vertebral bodies involved as a primary are not seen, means rarely seen in young age group, but commonly seen in old age group. So these are the two important causes, or you can say these are the red flags. How to identify these and how to separate this cause as a backache from other routine causes, I'll be covering in the clinical examination. Now coming to the next part. So age we have done in three sections: young age, middle age, and old age. Now sex. So some things are very common in females and some are common in males. So in male population, all the three of young, middle, and old are same, but in male population, males have some protection for osteoporosis because testosterone, which has a positive effect on bone, will be always present throughout the life of a male, right? So osteoporosis is not a thing which you should suspect or you should put as a major cause of backache in male. So otherwise, the classification or the causes of backache in a male patient can be again divided into young male, like what I told, young, middle, and old. Interestingly, female population will have some different story to tell as far as age is concerned and the cause of backache is concerned, right? So we have covered this. Now coming to the female population, if it is a young female, there is something called as honeymoon LBP. No need to explain this. Then post-pregnancy, postpartum. What happens during pregnancy? There was a very interesting research that cesarean section has its advantages, and people were of the opinion that cesarean section is done unnecessarily and all those things. But there was a very interesting research that what are the disadvantages of a normal delivery. Now one cannot fathom it out how a normal delivery can be disadvantageous. Yes, it can be, because whatever hormonal changes are going to occur, they are going to affect the musculoskeletal system whatsoever. On the top of it, if a normal delivery is conducted, it is going to cause some injury or the other to the sacroiliac ligaments, pelvic floor muscles, and they are going to weaken these. This process is going to process of normal delivery is going to weaken these muscles, and that leads to backache in a young female. Another important thing is post-pregnancy PIVD, prolapsed intervertebral disc. Reason being the same: increased abdominal pressure during parturition, increased central obesity, or the increase of uterine size during the pregnancy leads to more loading of the spine, and it can lead to prolapsed intervertebral disc. So these are the causes, different separate causes totally as far as female population goes. Now coming to a middle-aged female, this also is very different and interesting. It is not as straightforward as the middle-aged causes which we saw when we were dealing with the age factor. So in middle-aged, perimenopausal, dysmenorrhea. Think of these first before going to the mechanical causes. Dysmenorrhea, perimenopausal age group, and PIVD means prolapsed intervertebral disc, and PID, pelvic inflammatory disease. Infection, chronic infection, pelvic inflammatory disease, pelvic malignancies can cause backache, can present as backache in the middle age group or old age group. So perimenopausal fibromyalgia is one of the very common causes of a low backache in middle-aged group, and the reason is that after pregnancy, one of the things. This is an exhaustive topic, but I'm trying to run through it as fast as possible. And in old, osteoporotic fractures or perimenopausal fractures is very common in old females as against old males. So you can definitely separate. You can keep it in mind that old females will present with old females will have osteoporotic fractures as a major cause of low backache. Sarcopenia, kyphosis are other causes. Secondaries and facetal OA I have already covered. So that is how the history will tell you of so many things related to backache. Now in the history, again, important question is, I'll stop writing and I'll just stop sharing. Right. So quickly running through the next things. Once you know that age and sex are related to these many causes, you can start asking further question as to what was the onset of symptoms. If it is acute onset, it will be paraspinal spasm or prolapse disc or mechanical backache. If it is episodic, it will be, of course, facetal osteoarthritis. And if it is chronic, that is again muscle imbalance. Most important question in history is to be asked is, कशाने तुम्हाला बरं वाटतं आणि काय केल्याने तुमचा त्रास वाढतो? What makes you feel better and what relieves your pain? For example, in prolapsed intervertebral disc, the straight leg raising test will be positive. Bending forward will be very painful. So that will be told in the history itself that I cannot bend forward. Morning stiffness. Morning stiffness of back is very common in this, and it is more often than not related to discogenic cause or the facetal OA cause, facetal arthropathy cause. Another important cause of morning stiffness in as a low backache is sacroiliitis or inflammation of the sacroiliac joint and also hip joints. Another thing at what makes it worse and what relieves it is night cries. So we are all aware about night cries, that in tuberculosis what happens is, because of the inflammation, severe inflammatory response to the tubercle bacilli, there is friction of the vertebral bodies over each other, and due to when the patient is awake, due to the muscle force, the patient will try to prevent that friction, but once he goes to sleep, the muscles go into relaxation and suddenly he has to get up because of acute pain. So night cries is one of the important things in worsening the pain. And if the pain is in the evening hours after the whole work, it is more often than not due to muscle fatigue and lack of exercise. Side turning can make the pain worse in sacroiliitis and other inflammatory causes. And most important history in history is whether the patient has to stop while walking. That means that is intermittent claudication. What happens in intermittent claudication is, because once we start walking, the venous return starts building up and the veins engorge in the spinal canal. So if there is lumbar canal stenosis already, it will compromise the canal due to venous engorgement and patient will have to stop while walking. So that is important history. How long can a person walk? A person with backache, how long can he walk? And if he has lower limb symptoms and if he has to stop, you are almost certain of a diagnosis of lumbar canal stenosis. Then another important question to be asked are, what are the associated symptoms? Associated symptoms means whether other joints are involved, like in rheumatoid or spondyloarthropathies, whether there is loss of appetite, loss of weight, that will be in tumor and infection, and associated leg pain, that is radiculopathy, what we covered as. So radiculopathy is typically seen in root irritation, and the root where it travels. So L1, L2, all those dermatomes and myotomes are given in any textbook. You can refer to that, and accordingly the root pain will be told by the patient. So one has to ask this question at the outset itself, that whether the pain is associated with radiation to the lower limbs. Then I just saw one question relation to menses. So that is one more point in the history. And let me tell you, no history is complete without asking symptoms related to hip and sacroiliac joints. What are those symptoms? That if the pain is aggravated by sitting cross-legged, if the pain is aggravated while getting up from squatting position or chair position. If that is there, you should think in terms of hip pathology. So coming up to the quick clinical examination, what I usually do is, patient is lying down in supine position. You have to check power in lower limbs, then do the straight leg raising test. During the straight leg raising test, what is the purpose is to pinpoint the irritation of nerve root, which travels along the posterior side of the thigh and up to the ankle. Then if the straight leg raising test is positive, that means at 30 degrees the patient says I have a pain, that means it is positive. 30, 40, 50, up to 60 you can consider it as positive. If one can definitely go above that, that means SLR is negative. Then the figure of 4 test, as we do in sitting cross-legged, that is indicative of sacroiliac pain. Then check for hip movements and ask the patient to roll to prone position and palpate for specific areas of tenderness. If the tenderness is in the paraspinal area or on the sides of the, not in the center, that means it is related to muscle spasm, or if there is an associated history of trauma and there is tenderness along the side of muscles, means you should suspect of transverse process fracture rather than anything else. And if the tenderness is in the midline over the spinous process, all the other causes should be thought of, like infection, destruction of spinal bodies, ligament injuries, likewise. On the sides, that is in the sacroiliac region, specifically it will be tender in sacroiliitis, and in the gluteal region or over the greater trochanter bursitis of hip, the tenderness will be on the lateral aspect of the hip. And these things will fairly help you to arrive to conclusion and what tests are to be done further. So I think the time is such that it's going beyond time, and I hope I was quite clear about what is to be done and how the patient should be approached and what should be thought of when you see a case of low backache. The investigations are again X-ray, MRI, lab investigation, bone mineral density for osteoporosis. And I think we should have some other lecture if you invite me. I will be very happy to come. So that how to investigate and treat further a case of low backache. So I will be willing to take any questions. Treatment, yes. Treatment. The importance of rest cannot be overemphasized. I mean, any low backache, whatever may be the cause, whether it is it will be of varying degrees, but strict bed rest helps like nothing else.
The type answer.
Give any amount of analgesic, you give any amount of muscle relaxants, you give any injections, you give whatever, interferential therapy or physiotherapy, traction, belt, but making the patient lie down parallel to the ground, supine, lateral, prone, whatever position he likes, but he has to strictly lie in bed in acute conditions in young age. 5 days of strict bed rest has miraculous results, let me tell you that. So apart from giving only painkillers, do ask your patients to lie down in bed for 5 days strictly, only to get up for his daily course, like eating, toileting and other things. Nothing else to be done by that patient for 5 days, only lie down. That gives miraculous results. So that is one important aspect of treatment. And in PIVD, then MRI and all those things will come into role. So that sciatic nerve, or commonly called as sciatica, there is one question of role of sciatic. So you should be able to delineate why that sciatic pain is there. As I told you, in young patient, it is most likely due to prolapsed intervertebral disc. In middle-aged, it is most likely due to the osteoarthritis of joint. And in old age, it is due to osteoporosis and degeneration again. So once you know that, whether that sciatic pain is going to get treated with conservative management, like I told, with analgesic and these nerve-related analgesic like pregabalin and gabapentin, nortriptyline, yes, all those drugs, or whether it is going to require surgical decompression, that will be decided as far as the MRI is concerned. So first you have to be sure about the cause of sciatic pain. And so that depends on the tolerance. I mean, response of the patient. Some patients do respond very well in first 5 days itself. Then you shift them immediately to back extension exercise program or physiotherapy program. If not, then you have to investigate further in form of MRI and blood investigations and think of decompressing that particular. Question answers ला click करू का? तिथे 9 दिसतायत मला.
Dr. Manoj, will you like to moderate the question answer?
Sir, what could be the cause of severe low backache 2-3 days prior to menstruation every month? One question from anonymous attendant.
नाही येते.
नाही, येतोय त्यांचा ऍक्च्युली
मला ऐकू येत नाहीये. इथे Q&A वर क्लिक करून
मी वाचू का क्वेश्चन आन्सर सो दॅट विल बी इजियर. सो
So now, Madam Rupa Agarwal is posing all the questions from the attendees.
What about the transmission of L?
लो बॅकएक इन्क्रीज होतंय का? हा क्वेश्चन आहे.
It's a very interesting one and very relevant one. The question is whether work from home is leading to increased low back pain. Yes, the cause is continuous sitting in a chair, whereas if someone is not working from home, the cause of backache will be traveling. So if a person who is traveling long distance will be at advantage because he will have some rest at home, and a person who travels a short distance who is not having a backache due to travel will be at disadvantage while working from home because he has to sit for prolonged periods and in awkward position at home because probably at home we do not have those ergonomically designed chairs. Yeah, role of exercise is all. I mean, strengthening the back muscles is the key to most of the problems of low backache. And back extension exercise program, abdominal strengthening program, static core program, and to demonstrate it on webinar, it's very difficult, but I would like to do that someday in front of the audience because that really helps the patient. And if you teach them yourself, they will never ever forget that because his doctor has taken the efforts to teach him. So instead of letting that job to a physiotherapist, of course physiotherapists do that sincerely, but if you start the basic exercises yourself, those means the chances that the patient will do that are much more.
Pain in greater trochanter area cause.
Yes. हे इथून घ्यायचं आहे का? Work from home. How to diagnose psoas abscess? Okay, I'll take this one. How to clinically diagnose psoas abscess? Now, in psoas abscess, there are two types: acute pyogenic and chronic due to tuberculosis. So the history will be typically one of tuberculosis, as I told you, fever, loss of weight, appetite. Only then you will go ahead with the diagnosis of psoas abscess and think in those terms. So sonography is one of the most important investigations. And clinically, if you want to diagnose psoas abscess, there will be fixed flexion deformity in the hip. And if you try to extend the hip, he will have pain. Tingling.
Some patient is having pain in low back, pain and starts to tingling sensation on right leg, feels numbness, right shoulder.
Yes, this is very interesting question, I must say. We all do encounter these patients, those who say पूर्ण अर्धा अंगच गेले कामातून, म्हणजे right from the head, shoulder, periscapular area, the loin and the low back sacroiliac and the right leg as well. So what I have at times I ask directly to them, do they have a fear of hemiparesis? Because that is one very interesting psychology that the patient has a fear, and yes, he or she has seen patients of hemiplegia, and if they see that, they start perceiving the symptoms for themselves, and they do come with these symptoms. It's not that they don't have symptoms, they do have these symptoms, but once you take away the fear from them, most of the symptoms are gone, because logically there is no reason why one should have half-sided body pain. There is no reason in science given as such. Okay, role of EMG and nerve conduction test. It is in case of neurological symptoms, as I told, especially if the patient is having both lower limb pain or all limb pain and neurological signs. So there the cause is more in the nerves rather than the spinal canal itself. Back pain during menses, as I told you, there is during menses the blood flow to the pelvic organs is increased, that causes congestion, and congestion will lead to increase in the volume of that area, leading to stretching of the nerves, and that will cause pain. This symptom are start from normal delivery. Yes. When do you suspect depression as a cause in females? Yes, depression is in the perimenopausal age group. There is that is typically described as mood swings and all other symptoms, along with backache or neck pain or fibromyalgia. So typically this section in our society, गृहिणी ज्याला आपण म्हणतो, गृहिणी जी असते त्यांना असं कायम वाटत असतं की आय ऑफन आस्क क्वेश्चन इन फ्रंट ऑफ द हजबंड दॅट तुम्ही काय करता ताई, अँड अनफॉर्च्युनेटली द आन्सर इज काही नाही करत. अरे काही नाही करत कसं? शी हँडल्स द होल, शी इज द मेन ऍक्सिस ऑफ द होम, शी इज द सेंट्रल ऍक्सिस ऑफ द ऑल द डोमेस्टिक ऍक्टिव्हिटीज अँड द फॅमिली. So if she says that ki mi kahi nahi karat, that means she is in depression. She has underestimated her services so badly that she says that she does nothing. Then I have to pump in the confidence, or we have to pump in the confidence that she is the main axis and she has to take out time for her exercises and all those things. Yes. Yes. Any non-steroidal anti-inflammatory drugs like etocoxibs or will start from diclofenac, and then ibuprofen, then mefenamic acid, then the newer coxibs. They all have the same role to play. They will reduce the inflammation, whatever is there due to the joint pain. They will not relieve the spasm. So you have to add a muscle relaxant if there is a spasm. And if you take away the spasm, you are taking away the natural protection of the nature has offered a protection due to spasm so that the disc doesn't come back, right? So if you take away the spasm, the disc is going to come back, which you don't want to happen. So the importance of bed rest is there. So whatever drugs you give, if those include muscle relaxants, means if there is a muscle spasm and muscle relaxants are needed, concomitant bed rest is a must.
So muscle relaxant, would you recommend?
Yeah, that is according to the pain. So if the nowadays what I do is, if the main complaint is only backache with radicular pain, means the root is involved, I try to avoid muscle relaxant. Instead, pregabalin acts, or pregabalin nortriptyline combinations. They do act very well on both the backache as well as the root pain. So there you can avoid muscle relaxant. But if the history is one of a severely acute backache due to lifting weight and you have suspected muscle injury, then nothing works like thiocolchicoside or cyclobenzaprine or any other drug which relaxes the muscle. Tizanidine was a fabulous muscle relaxant. It used to put the patients to sleep a lot, but then nothing act like tizanidine. It was one of my favorite, but with cardiac side effects, it has been withdrawn from the market.
Lot of questions.
As long as you are giving, there is one question from Dr. Kushal that which salt of calcium is important in osteoporosis. So whatever salt you use, it should not have gastrointestinal side effects. Carbonate usually has gastrointestinal effects like constipation or something. That is also very uncommon actually. But then instead of carbonate nowadays, citrate maleate is preferred, and you should be giving the proper elemental dose. So there is a chart, 1250 milligram equivalent to how many elemental calcium. So 400, 200, 400. That is a rough this thing. 400 in young patients, 200 in middle-aged, and 400 in old patients for treatment of osteoporosis. That much elemental calcium you should be advocating.
One patient complained of tingling in the upper limb, second complaint of tingling and numbness in upper limb, and third complaint of tingling, numbness, and pain in upper limb. Differential diagnosis.
First is only tingling.
Tingling, second tingling with numbness, and third tingling, numbness, and pain.
These all are related to nerve root symptoms and with varying severity. Now, if you ask me, there is pain. Usually there is pain first. Once it has pain is a nociceptive sensation, right? Nobody wants to have pain. Once the pain shifts to tingling as well, the severity has increased. And if there is numbness as well, then the severity of nerve compression is increased. So you should take into consideration that. And then you should check for motor power as well. So I would like to add the fourth one. The question is related to 3 symptoms. I would like to add the fourth also, which is a sign. You should check the muscle power. If the power is lost, that means the severity is still more. Severity of compression or nerve involvement.
Spine surgery be recommended in low backache?
Okay, low backache per se doesn't warrant spine surgery at all. If it is associated with radicular pain, it is very rewarding. Whatever may be the cause of low backache, no surgery is going to help in low backache, right? Because when we do surgery, the basic cause of low backache is weakness of muscles and degeneration. And on the top of that, we are going to do something minus out of the spine when we operate on it. We will be injuring the muscles surgically, we will be injuring the ligaments, the joints, we will be taking out disc, we will be fusing the joints, something or the other we will be doing, and that is going to affect the low backache further. So low backache per se is never an indication for surgery. It has to be associated with other symptoms like radicular pain or spondylolisthesis or spondylolysis where there is instability. Only then it is rewarding in low backache. Otherwise, only low backache, no surgery.
Hello.
Increases after rest, what should we think of as that?
Yes, that I told morning stiffness. If it is increasing after rest, that means it is related to joint pain because during the night hours, the joint accumulates, the synovial fluid accumulates in the joint. No fresh oxygenation is given to the cartilage, and the pain producing substances keep on accumulating in the joint and cause pain. So after inactivity, if there is pain, it is more likely due to the facetal joints or the zygoapophyseal joints of the spine.
Hello.
Inflammatory disease, that is a, straightforward thing, and you
Hello.
have to give antibiotics and all those things. High heels and low backache. Well, the biomechanics of low backache, again, this is a good question because flat foot is going to cause someday or the other knee joint pain and backache as well as the age progresses. So high heels per se, if they are pointed, will lead to more fashionable and pointed will definitely lead to change in posture and can cause low backache. But if they are broad, I don't think, because broad will be well balanced and the muscles will be under less stress.
Is it mandatory to take continuous calcium supplement at menopausal age and for how long?
See, during the menopausal age, There are, we can classify osteoporosis at the menopausal age. Like after menopause, certainly there is going to be osteoporosis, but there is a certain group called as freak losers. Freak losers meaning thereby the calcium loss is so rapid and so pathological that you have to take vitamin D with calcium and the newer drugs like teriparatide or bisphosphonates to prevent osteoporosis. All in all, one has to take the family history, whether the mother of that particular patient has suffered from osteoporosis. Is there any indicative history of osteoporotic fracture or so? If that is so, you should give that particular patient continuous calcium to prevent osteoporosis, along with vitamin D.
What type of bed is best suitable for sleeping?
Yeah, that is again an interesting one because many patients do ask this, and I would try to make it very easy. It should not be, people do come and they say that I do sleep on um, floor, satranji. That is not necessary. In fact, the body contour is disturbed when you lie on that hard a surface. So routine cotton mattresses are the best ones, or the coir, which has some stiffness. At many five-star hotels, you must have experienced the sudden giving way when you sit on the chair or you lie down on the bed. It just dips you down. That is bad for back, because then what happens? There are certain pressure points and certain parts of the body remain unsupported. That causes problem.
Postpartum backache specific exercises.
Pelvic floor exercises, back extension exercises. There is a proper exercise program for immediate postpartum period.
In facet degeneration, what is the treatment?
Well, facet degeneration will occur due to disc degeneration. So you have to treat it accordingly. And if main thing is rest, analgesics, anti-inflammatory drugs, cartilage healers like collagen peptide and all, those do work wonderfully. With gradual exercise, interferential therapy, all combinations can be tried. Interesting thing about facet degeneration is, if the facet joint swells up to that extent and the synovial fluid protrudes out and starts pressing over the nerve, it will act as a prolapse disc, right? This comes from the front, whereas the joint fluid or the synovial outpouching of that joint will come from the back. So there you can try root block, the facet block injection under Siam IITV guidance. That works wonderfully. So facet joint in particular, what is different from other backache is you can try intra-articular injection under Siam guidance.
Advice of endoscopic surgery over open surgery in disc related surgeries.
This is slightly controversial, but I am not a very big fan of endoscopic surgery because it is difficult to tackle all the structures through a scope, and I found many recurrences and things. But a classic indication of endoscopic surgery, if you ask me, is a single level disc in a young patient who wants to get back to work very early. Yes, it is rewarding.
Hello.
Acute low back pain on standing on for 1 hour continuously. What should be the cause? Is it so bad? It is so bad that she has to support her waist with hands and sit immediately.
So this is obviously related to mechanical problems. So one should investigate in form of plain X-ray. That brings me to a very important, very nice question, because this will throw some. What X-ray will you advise? So usually in this world, we don't have any investigation which tells you as to what happens while the patient is loading the spine, meaning thereby while standing or sitting. All investigations are done in lying down position. But now, after the MRI is also done while the patient is lying down. So MRI will show you the nerve root, but it will not show you what happens to the nerve root when the spine is loaded, right? So standing X-ray films with flexion and extension, AP plane, lateral in flexion and lateral in extension will give you the instability and how the spine is loaded while the patient is standing. That investigation will help in such a patient.
Occasionally, some patients with divergent.
Oh, wait a minute. Backache due to spinal anesthesia. This is a big काय म्हणतात अंधश्रद्धा. शकत नाही. Backache can never occur due to spinal anesthesia. The needle used is very yes, due to spinal anesthesia, headache can occur because of the epidural cerebrospinal fluid loss. And if the patient mobilizes herself or himself very early after the spinal anesthesia. So lot of fluids are to be given after spinal anesthesia. And if the patient says that after my cesarean section, I have taken that injection there and I am having backache, try to reassure her in every possible way that that needle is never going to cause backache. Yes, your question.
Occasionally, some patient with psychogenic pain treated
In occasionally?
ICO psychogenic, discogenic pain treated with injection in ankle.
Ankle joint, yes. That the same nerve root supply is there. The L5 root does supply the ankle as well. So it is called as counter-irritant mechanism or what we call as the referred pain. So that is a classical sign described by our own Pune, proudly to say that Dr. Satish Chandra Gore. He has definitely proven it beyond doubt that injection in the ankle does help, but it has its own limitations.
My patient, 50-year-old healthy female, she has got burning sensation in all toes only while lying down at night. Neurologistला दाखवलंय तर कुठे neurological problem नाहीये, B12 normal आहे. So what can it be? Any suggestion?
Idiopathic sensory neuropathy. No cause known, but then there is sensory neuropathy. These patients do respond very well to nortriptyline rather than pregabalin. So Sensival is the tablet. It's a very cheap tablet. 25 milligrams of nortriptyline at night works wonderfully.
It affects on sexual life?
Yes. And when it should be given. So so the nerve root will be causing pain due to two factors. There is something called as mechanical pressure and another is the chemical cause. What is mechanical cause? As I told you, the annulus fibrosus is intact and the disc has herniated and it is pressing over the nerve. So this is a mechanical pressure, right? The nucleus pulposus is not in contact with the nerve at all. It is separated by annulus fibrosus. So here probably the nerve root block is not going to work because any block when we give, we try to subside the inflammation over there with corticosteroid or any other drug. So when a nerve root block will work, if there is a small amount of nucleus pulposus which has broken through the annulus fibrosus and has come in contact with the nerve root, leading to a strong inflammatory response, there the nerve root block is going to work.
Correct dose and how frequently should be repeated?
There are so many articles in the net, but there was a fantastic research in Nizam Institute of Hyderabad. They gave 60,000 units of vitamin D per day for 10 days and with nothing else in low backache. Nothing else, not even a single analgesic tablet. With rest and 10 days of vitamin D continuously. And they claim that it has worked wonderfully. But then what I want to say is, as far as our routine practice is concerned, you should give weekly dose of 60,000 international units, say for 8 to 12 weeks, and then follow it per month forever. Yes, vitamin E will act on the muscle pain rather than joint or any other thing. tocotrienols or vitamin E is known to have a very good effect on calf myalgia and backache as well. But once given for 6 weeks or 8 weeks, maybe daily, it is sufficient for lifetime because it is stored in the fat and then it suffices for lifelong.
We are really happy that I guess most of our queries have been answered today. Here, definitely, there was a lot of efforts involved from our scientific chairman, Dr. Praveen Dara, and scientific advisor, Dr. Prakash Mahajan, sir. I also take this opportunity to invite the people who are not GPA member to become GPA member and enjoy such many other scientific sessions along with us. I thank Dr. Rishikesh Badwe sir for this beautiful, starting from very basic anatomy to very simple blackboard wala type मध्ये whiteboard learning classroom session to taking us to the nerve root related surgery related question answers and answering most of our questions. So at the same time here, I thank DG Shield for their technical support, and it has been a really beautiful session, and we expect you all to keep joining us on every Friday for similar sessions. Thank you, everyone. Before ending the session, I would request Mr. Zipin ji to introduce DG Shield to all our doctors. And it is a very beautiful panel, the teleconsultation related company, about which we will know little more from Mr. Deepan. Sir, hand over to you.
Thank you, GPA, for giving DigiShield an opportunity to associate with you and organize such a wonderful webinar. My name is Deepan Mehta. I am a CEO of DigiShield, and Mr. Sanket Barale is our founder chairman of DigiShield. He is also like founder of FigMD, which is a Pune-based company and backed by Google Ventures, which manages almost 40% of data of US citizen. So like actually due to his urgent meeting, he has apologized for not attending the session. We have made a software DigiShield, which is an AI powered solution, which uses the artificial intelligence to help doctor understand the COVID carrier risk of the patient before patient visits to the clinic. So doctor just need to book the appointment. Patient will receive the SMS link in which chatbot will get connected with the patient, and patient just need to enter like 14 to 17 parameters. So through artificial intelligence, patient's risk will be recorded, and it will be shown by the to the doctors, like if patient is of high risk, low risk, or medium risk. So accordingly, doctor can assist the patient and do the consultation. Even doctor will receive the digital consent of the patient. So it's not only like COVID carrier risk assessment. You can do teleconsultation, video consultation. There is a touchless payment collection, online appointment booking. Various other features are there. I will just show you some short video, so you will just get to know how it is used.
Download the DigiShield app from the Play Store or App Store now. New users will go through a quick one-time registration process. After filling in some basic information, registration is complete and you can start using DigiShield. Logging into DigiShield is easy, safe and secure. Enter your registered mobile number. An OTP is sent to your mobile. Enter the OTP and you are logged in. No passwords to forget. Making a patient's appointment is easy. Just click on the calendar sign, enter the patient's name and mobile number. Select date and time of the appointment, and that's it. A confirmation message will be sent to the patient, and so will a reminder. A day before the appointment, your patient will be automatically contacted by the DigiShield agent. The Shield agent will collect the patient's symptoms, history of present illness, and more. The agent will also collect any consents or indemnity that you want to collect from them. Based on the DigiShield interaction, you will be alerted to the patient corona carrier risk. It's easy to do a phone or a video consultation with the patient. DigiShield recommends that patients that have been flagged with a high or moderate corona carrier risk should be consulted via consultation first. Click on the phone icon or the video icon to do a safe and secure teleconsultation with the patient. In order to issue an e-prescription to a patient, tap on the pencil icon, tap on the camera icon to take a photo of the prescription, and you're all set. The prescription is sent securely to the patient immediately. DigiShield is easy to use and you will be online within 5 minutes of downloading the app. Download DigiShield on the Android Play Store or Apple App Store today. Protect yourself, your patients, your community. Download DigiShield for free today.
So the application is available in Play Store as well as in App Store. So it's free for the doctors. You can start using. If you have any concerns, you can just log on to www.digishield.me and start using. Thank you, Dr. Rupa. We'll hand over to Dr. Rupa for further. Thanks.
Thank you, Dr. Rishikesh Badwe, sir, for today's wonderful and knowledgeable lecture, practical approach. खरं तर सर नुसते हाडांचे डॉक्टर नाही तर हाडांचे शिक्षक म्हणायला पाहिजे. त्यांनी आपल्याला व्हाईट बोर्डवर चांगलं शिकवलं. Thank you, sir, and thank you, DigiShield team. Thank you, today's convener, Dr. Manoj Deshpande, and above all, thank you all audience who are present here. Thank you all.